Good morning. Today I will show you or share with you a few tips and tricks that we learned from physicians using the CAVI-T asymmetric balloon. So this is version 1 of the balloon that most of you have been using, and recently we launched the version 2 of the product. And so if you put version 2 on top of version 1, what you can see is that there is a shade that is slightly different, with a polyurethane film that is steeper in the entire portion of the device. I will tell you in a minute why is that, and how it can actually help you in certain situations. Regarding insertion of the device, there are some videos already that were made. Not getting to the details of that. What's really important though is that you always keep an eye on the markers located on the deployment guide. That's one thing that is absolutely key. And second, make sure that the film stays close to the septum in the direction of the olfactory cleft to ensure proper deployment of the balloon. So here I will insert till the first marker reaches the nasal ala. I will grab 20 cc of air and inflate my balloon. Okay, so I put 15 cc of air in the balloon, and here you can see how it conforms to the anatomy. Marker 1 is still visible here on the deployment guide. You can then remove the guide and tape the spiral tubing on the cheek of the patient, while making sure that this tubing is not too much under tension to avoid any necrosis of the nasal ala. Then what's important for the users familiar with double balloon catheters is really the depth of insertion. So here you see that it's pretty anterior because it's marker 1. Marker 1 will be more suitable to anterior bleeding coming from the Kisselback plexus, whereas marker 2 is more suitable for bleeding originating from the sphenopalatine artery. So let's imagine in that case the patient continues to bleed despite this anterior or relatively anterior positioning. You insert the guide once again in the breathing channel. You fully deflate the balloon, and then you advance the balloon further until the second marker reaches the nasal ala, and then you inflate again. Now you can see the positioning is different, much more posterior. You can remove the guide, and that's it. What can happen again with users familiar with double balloon catheters is that when they advance the balloon, they go too posterior. In that case, that will increase the risk of posterior migration of the balloon. So let me show you that. So if instead of taking a look at the second marker on the deployment guide, you advance, for example, much more, in the spirit of what is done with a double balloon catheter, with the need to properly deploy the posterior balloon first, then I advance a lot. And then guess what? When I do that, look, the balloon, there is a movement that is making the balloon move posteriorly, and this is actually something you need to pay attention to. Deflate the balloon, Okay. So now let me remove everything straight away. Okay, just now to show you the second version of the balloon, which is this steeper version in the anterior part. I will do exactly the same. Please note that because the balloon is more cumbersome, you know, it's bigger, it is necessarily more complicated to deploy in the nasal cavity and have something that will really nicely conform to the anatomy. Follow the same steps anyway. So you check the markers, you stay close to the septum as much as you can in the direction of the olfactory cleft. And then when the first marker is well positioned, grab 20 cc and advance. Okay. Sometimes you need to do what I did here, which is you can see initially some wrinkles on the balloon. Of course, you will never see that in an epistaxis patient, but you can try to inflate, then deflate, then reinflate a little bit. That will, let's say, facilitate a proper deployment of the balloon in the nasal fossa. As you can see, it conforms nicely to the anatomy. The main difference between version 1 of the balloon and version 2, which is this one, is that the coverage of the anterior portion is really much nicer. However, again, it's always a trade-off. You will have a better coverage of the area because of the steeper, anterior portion. It will be more challenging for the balloon to migrate posteriorly. However, the trade-off is that it's more challenging to deploy. So you need really to find the right balloon to address your clinical needs. So let me deflate. In that case, that was really an anterior positioning. Well, I forgot, of course, to remove the guide once inflation is resumed. Okay, so now let's assume that the bleeding is originating from the sphenopalatine artery. So usually what you do with traditional products, you will just remove the product and use a new treatment modality, because you cannot advance further a tampon or most of the devices out there. So you will remove it and use another one, which is annoying for you and even more annoying for the patient. So in that case, you will just take your deployment guide again, advance it in the breathing channel. You will deflate the balloon fully, and then you will advance till you reach the second marker. Here we go. Second marker is here. And I inflate again. And I remove the guide to finish the procedure. Now you can see it's properly covering this posterior part. You just need to tape the tubing on the cheek of the patient. As before with V1, make sure that you do not put it too much in tension to avoid necrosis of the nasal ala. You can see now that we have a straight portion of the tubing that will facilitate taping on the cheek of the patient. So same with that product. If you advance it too much, there is clearly a risk of posterior migration. I can show you real quick. I deflate. So let's imagine I proceed a little bit like I would proceed with a double balloon catheter. So in other words, I go quite far, and then I will just inflate. See again the balloon, although this steeper portion will help drastically reduce the risk of migration, the balloon had a movement in the direction of the nasopharynx. So if I try to summarize, always use the markers, do not advance further to reduce the risk of migration, position the product really as medially as possible on the side of the septum and the olfactory cleft. Do not overinflate, even with this balloon which is bigger than version 1. You should try to keep the inflation at a reasonable amount. It might be in that case, because the balloon is bigger, a bit more than 15 cc, but if you can keep it between 15 and 20, usually it's enough to do to control bleeding. Then make sure that you verify at the end of the procedure the stability of the device. You use a little forceps and you push and pull just to verify that it doesn't move. And last, you just need to tape the tubing on the cheek while avoiding that tension is too important to eliminate the risk of nasal ala necrosis. Please also bear in mind, should it be V2 or V1, as mentioned before, there is no need to use silicone oil, as it would actually reinforce the risk of having a displacement of the product. So we do not recommend it. Although you can always decide to use some, especially with V2, which is a bit more challenging to deploy. But just make sure you are actually cautious when using that.